Hi, Nikhil. I'm looking forward to catching up with you today. You and I met during our CDC Global Health Fellowship starting in 2016, and then we both pursued PhDs. Your path has spanned global surveillance at CDC, doctoral research in environmental sciences and epidemiology at UNC, wastewater-based epidemiology during COVID, and now leading North Carolina's climate and health program. You have also worked in the Democratic Republic of the Congo in your master's and sub-Saharan Africa, especially Cameroon and Cote d'Ivoire, while at CDC. Your work really sits at the intersection of data, the environment, and population health. I'd love for students to see how climate hazards, infectious disease, and surveillance all connect in practice.
Hi, Larissa, and hi, everyone. My name is Nikhil Kothegal. I'm happy to talk to you today. And maybe I can just share really quickly, too, in addition to what you said. So I am living in Chapel Hill, North Carolina, and I am the climate and health program lead in our state health department, which is situated in Raleigh, North Carolina. And I am also finishing my PhD, which is in our School of Public Health. And specifically, I'm in the program, which is Environmental Sciences and Engineering, which is kind of like environmental health. And yeah, I've been working on hurricane and flooding related issues during my time in North Carolina. So thanks.
Thanks for that. Yeah, you've done a lot. Thank you for adding all that. So I have a few questions for you today. My first
Sure.
question is about global burden of disease and surveillance. So we knew each other at CDC. From your time at CDC and working on the PHIA, Public Health Impact Assessment Surveys, PHIA, how did global HIV TB data collection shape your understanding of surveillance?
Okay. Thanks, Larissa. So for any of your students who may not be familiar with this, so I worked at CDC under the Division of Global HIV and Tuberculosis, which is what the TB is. And a lot of us were funded by PEPFAR, which is a President's Emergency Plan for AIDS Relief, which was funded under George W. Bush in the early 2000s. And I specifically worked on these PHIA, or population-based HIV impact assessment surveys. It's a little bit of a jumble, and it's an acronym which you'll see anyone who works in public health. We have a lot of those. But basically, those were surveys that were designed to understand how well the PEPFAR program was working. And PEPFAR was funded basically to deal with the HIV pandemic that was happening in many countries around the world, especially in sub-Saharan Africa. And so as part of my work, we were hoping to lead household-based surveys in countries all across sub-Saharan Africa to really get an understanding of what was the current status of the HIV pandemic in those countries. And we specifically were looking at the general population, so people that you can identify at the household level. So that would be just like, generally heterosexual households, things like that. So that's different than some maybe key populations that might be like sex workers or injection drug users, things like that, which we know in public health, there can be stigma against that and they might be harder to identify. So when we talk about surveillance here, we're talking about kind of a general surveillance strategies at the household level. And
Yeah.
I'll say that, oh, go ahead, sorry.
No, thank you. Yeah, keep going.
So I think what I understood and learned from participating in the PHIA surveys is just how much, like the importance of standardization and quality data collection. So when it comes to something like HIV, what we were collecting, we had a combination of survey questionnaires that were asked of the household, as well as individuals in the household. We combine that with biomarkers. And what I mean by that is testing of people's blood at the household level. And when we collected people's blood, we would test for HIV with a rapid test. And then we would also check people's CD4 counts to see if they were immunocompromised. And so we combined the very rich data we could get from people from a survey, questions about people's behaviors, their marital status, do they know if they're already HIV positive, are they on treatment, things like that, other kind of behaviors, with then something that is a little bit more systematic, like a biomarker, and we can compare those two together. And we can also then understand what are potential risk factors if somebody is HIV positive. And so going back to that question of surveillance, I would say that there are many ways to conduct surveillance. In this case, you're trying to find methods that are very systematic and generalizable. So you can, in this case, survey a relatively small number of households in the country, and by using different weighting strategies and things like that, you can then understand what is the situation of the HIV epidemic at the whole country level. Obviously, it would be very expensive and very time consuming if we had to go to every single person in every house. And while we care about everyone in the population, we know that's not feasible. But with some kind of systematic surveillance like this, we can then understand at the country level kind of what proportion of the population is HIV positive, and if people are on treatment, if the treatment is working, and then who are the people that were missing. So who are those people that may have been HIV positive that didn't know until we interviewed them and tested their blood, and it helps inform how we can improve our programs. So that's, in that case, the surveillance data is actually used to help us really combat the HIV epidemic. And it also was a way to see how over a decade of funding and programs in these different countries were, whether or not it was working, to see has HIV prevalence, so just all the people who are living with HIV, if that's gone down. And we were also able to look at HIV incidence to see, okay, so are there people who are newly infected? And that question is important because, as we know, there's no cure for HIV, unfortunately. So over time, as people are getting treatment, they're living longer with HIV. So we know that the prevalence will continue to increase as more people are infected, but they may not be transmitting the virus to other people. But we also want to understand, are there people who are newly infected, and what are the kind of the risk factors that might have contributed to them getting infected?
Well,
Thanks.
yeah, I'm sorry to laugh, but it's just that there's so many aspects to surveillance. And you're
Right.
just going through all of them one by one by one, and it's just making me realize how complicated of a question this was, that this is a huge question. But thank you for shedding some light on it. And I have more questions as well.
Great.
So my next question is about determinants of health equity. Can you
Okay.
share an example of how data collection for health research and programs can consider different social and cultural contexts and equity?
Great. Sure. I'll go back to those PHIA or PHIA surveys here. So I think this is a really important, the question of health and equity is really important when we think about doing global health. I am an American. I'm coming from the United States, and with behind the dollar and funding from this PEPFAR program, and I was working in many different countries in sub-Saharan Africa. All of them have different histories, culture, and so we have to understand that we're coming into another country with a different population. Most of those places I had never been before in my life. And so when we're doing that work, you want to have a lot of humility. Also, in the nature of global health, there's a very big movement now to really build up infrastructure in the countries so that countries are much more self-sufficient, having better training. They own the data from something like a survey like this, and that they're building up their own technical capacity to be able to have laboratory testing, statisticians, things like that. So they're less reliant upon outside help, like from the United States. And then it's also important, I think, just to recognize that across different cultures, different religious backgrounds, certain things may be considered taboo that in our own country may be or my own personal beliefs may not be taboo. And HIV is one of those things that, there's a lot of sensitivities, and people don't necessarily want to be outed as being HIV positive. So you have to think about that. There can be a lot of stigmatization too around um, if people are getting tested, who's getting tested, and then if people are getting on treatment if they find out they're positive. So there's a lot of different things like that if we don't think about the social and cultural context, we can make some kind of a situation worse actually, and people's health outcomes can actually worsen over time rather than seeing the improvements that we want. And then I think equity in this case is just making sure that we're really trying hard to make sure we don't leave people behind. So in my case, we were again going to the household. So we're not targeting everyone in the population, but we really want to understand like what age group and what demographic characteristics of the population are people that maybe weren't getting tested, or are there certain characteristics of people, like if they've experienced violence in the household or something that might make them more susceptible to contracting HIV, things like that, due to other social circumstances outside of their own immediate behaviors. So, yeah.
Yeah. And did you want to mention anything about your work in the Democratic Republic of the Congo?
Yeah, sure. So, as Larissa mentioned earlier, during my master's, I worked in the Democratic Republic of the Congo in the middle of the country in a very rural area. And for that project, I was working as a water sanitation and hygiene intern. And that was my first time going to sub-Saharan Africa. It was in a very rural country that's often known for a lot of political turmoil and things like that. And so um, definitely I came into an environment that was very different than my living context in the United States. And there we were working to do a combination of things, testing people's water supplies. So like people's wells and more like unimproved water sources. And then we were also educating people on how to do some simple tests to see if they had E. coli in their water, um, how to use water, providing people with water in communities with water filters, and then showing them how to use them effectively, how to maintain them, things like that. And so it was very important to understand that there are a lot of different cultural and behavioral practices. People may be more accustomed to drinking from the water from natural sources that their ancestors drank from. And
Mm.
so also explaining kind of like that, like what is meant behind the science and some of the testing, which might be a little bit more um, for people who have less formal education, like what does it mean to do these tests, and kind of translating how contamination of water leads to infections and things like that. But I'll also say that one thing I learned a lot of in this case was it's one thing to kind of participate in the scientific side of things. So I can test the water, and then there's this like fluorescence, and I can show that, hey, when this tube fluoresces, it means there's a pathogenic E. coli in there. But it's another thing for people then to be empowered to be able to take that knowledge and change their behavior and practices to, um, drink safe water, clean water. And so part of that was providing um, different kind of disinfectants or water filters, so people had access to that. So we could tell people that their water may not always be safe to drink, but they may not have the resources to have clean water unless we work with them on that.
Mm. That really transitions to my next question for you about communication. So, when you're doing program design and implementation, how do you
Mhm.
incorporate health communication and education for the public when you're designing this intervention? And could you give an example from your experience?
Sure. So I think with communication, it's really important to understand who's your audience, right? And so we have to think about what educational background people have and their literacy level. What's their culture again, things like that. Like, where are the areas that people congregate? So in some areas, like communicating public health findings and reports through a body like a religious organization, like a church, might be a very good way where there's already trust there, and it's a place where you can leverage that trust and the community participation to share public health findings. So that's something I would think about. Also, understanding that in public health and in global health, we want to make sure that we're not just extracting data. So while a lot of times people are conducting research and we might want to conduct a survey, or we might want to collect water samples and we publish it in a paper, that may not have a direct and tangible impact on someone's health and life. And so it's very important also that we are sharing our findings with the public, and also, if we can, working with the public to help inform our research questions, the things that we're exploring, so that as outsiders, we may be interested in certain factors that are less important to the population we're working with. And so also think in terms of that kind of communication, having kind of community informed research questions are very valuable. And often it's the local context that is very informative to somebody to guide our research, where we're going to sample, things like that.
And it's a great transition to talk about bringing that up to policy. So
Okay.
What have you learned about turning that complex environmental and epidemiological data into actionable policies to advise decision makers?
Great. Yeah, in many aspects, I think, policy is something in public health I think a lot of us want to impact. So we care about improving health outcomes, and a lot of times that means we have to first collect the data. We have to analyze it, assess it for biases. We have to basically develop the science, right? And then we have to translate that somehow into laws that protect people, that reduce people's exposures, things like that. So one thing I can share is sometimes in our work, we're not always engaged in the long-term policy endeavors, and we're collecting data, or I can say at CDC with the PHIA data, I was often asked by other programs to do analysis of something in our data, and then I would send it to them, and then they might use that result then to put it into a model to better understand some nature of the HIV prevalence in a certain population. And then that might be used to basically develop a program or policy down the road. So even though I wasn't involved in that in all the parts downstream, it's like that data and the analysis helped inform those decisions later. The other thing I can say too is like around questions of environmental health and justice. A lot of times you'll see communities, and this is in the States and also globally, where community members may recognize that they're being impacted by some exposure, some form of pollution, and they're looking for a means of like remediating that. And so that's where I think we can work together to design a study or to provide that evidence, which can then inform policymakers. And sometimes it's not enough just for people to say, okay, we know that the air is polluted around our area, or the water that we're drinking is contaminated. But when we can also provide some scientific evidence and testimonies, that then can be submitted or brought to court. And so there's often, court cases and things like that, which can actually lead then to stronger regulations and changes in policies that may reduce pollution levels, or, chemicals that are produced or things like that that will ultimately improve people's health.
Yes. Well, moving forward to, thank you for that. And moving forward to the
Mm-hmm.
specific methods and tools that you use to do those things. You've worked with wastewater surveillance, R programming, large survey data across health issues. Which analytical tools and methods do you consider most essential for today's public health students to learn?
Great. Um, I definitely think being able to use and work with data and understand, I guess, like the complexities of data, different types of data, and different study designs is really important. I'm not sure how much the students have taken like an epidemiology course, but like understanding a cross-sectional data or cohort data or case control or randomized controlled trial, all of these are different type of studies that serve different purposes. And honestly, I don't think there's one gold standard because in the real world, often our data is observational also, especially with environmental health. We don't experiment on people. So a lot of times you have to collect data um, as is and see what are people exposed to. And um, I think it's very important also to understand as best as you can, what are the limitations of the data you're working with? Are there any biases, things like that? Um, so when it comes to say wastewater surveillance, I have a lot of friends who were working on wastewater surveillance during the COVID-19 pandemic, which was basically, collection of wastewater samples and looking for the SARS-CoV-2 virus and at the population level, and then looking at the concentrations of that to kind of see, are we having increases in the COVID-19 prevalence or decreases? What are patterns that are happening? And you can do this for um, all different kinds of viruses and things that are found in wastewater. Um, it's one thing just to take that data and to analyze it. And it's another thing to work in the lab side of it, where we actually went to the wastewater treatment plants, collected the data, collected the water samples with the people working there. So we got to see, how are they collecting the water? Is it over a longer period of time? Is it one collected, at one point in time? When we're working in the lab, how are we extracting the RNA? Are we making mistakes? Things like that. And so you see the process of how kind of the data is made in a sense. And that can be very informative for understanding what are its limitations.
Hmm.
And I think not
Yeah.
everyone, you won't always get to be involved in all those steps, but it can be very informative. And I think, I say this to the people who I supervise now. We're not all going to be statisticians. We're not all epidemiologists. And so having a broad set of skills is okay. And we all have, in public health, we all have different roles. But I do think if people can do some basic statistical analyses, like in some program like SAS or Stata or SPSS or Excel or R, it can be very helpful. One, because you can just, do simple calculations if you want to investigate your data. And two, you can be just a little bit more independent and, conduct some research. But as there's always going to be somebody with a little bit more biostatistical training or statistical training, and that's okay. And obviously in public health, we work together. So I know that there's always going to be somebody who I can rely on, and I'll reach out to them for support.
Mm. Yeah. Yeah. I think that's a great point that though a lot of people recommend you learn it, though some basic level of biostat is usually a part of most public health education and core courses. If that's not your thing, don't write it off. Still try to be as informed as possible. So when you're working on a collaborative team, which public health, like you said, is collaborative, you can at least be familiar enough to maybe ask the right questions and to understand what you're looking at when you talk to that person. So that's good. And I know your background is very like you're a stat guy amongst other things,
No.
but more than me. But my last question for you was about career paths and other skills. besides the
Sure.
ones you've already mentioned. So which skills from your own training, epidemiology, biostat, communication, but also diplomacy, turned out to
Mhm.
be most useful in your day-to-day work as a health researcher, globally and domestically?
Sure. Thank you. I think this is an extremely important question. And for students who are young and you have time to take classes, to learn new things, not working hopefully full time in a career like, your professor and I are now, things I would recommend, excuse me, maybe I'll start with language. So I was fortunate way back in the day. I never thought that I would go into public health. It was not something I was considering. But in my undergrad, I was studying French and Spanish and international studies. And those were instrumental actually to opportunities that came my way in public health. So I don't think I would have ever had the fellowship at the CDC if it weren't for them needing somebody who could speak French. And I had studied abroad in France, and I was very honest that I wasn't lying. I had capacity to work and speak French, and they could rely on me to be in the field and be independent. And I actually worked a lot on providing training and all this kind of survey terminology in French in both Cameroon and Cote d'Ivoire. And similarly, I was able to use my French before that when I worked in the Democratic Republic of the Congo. Now, one funny thing is that depending on where you work, you'll see that even a language like French, which a lot of people in the United States may not know, is still not sufficient because there's more local languages. That's really what most people will actually speak. And so, I couldn't communicate during most of the PHIA surveys with the people at the household level, but I could speak with people who were in the Ministry of Health, things like that, who are kind of higher level up that spoke French. But I wasn't, familiar with the local languages. Um, so, language is very important. I think, as I mentioned earlier, kind of like cultural humility and curiosity is just really important because if there's anything in global health, you have to be open-minded. I have slept in random places. I didn't always have food to eat. You do your best. You try not to get sick. I took my malaria prophylaxis. Um, but yeah, if I were very particular about certain things, which maybe I am at home, but when I get on the road, I try to be very amenable and do the best I can to be. Yeah, I was a vegetarian, but when I went to the DRC, I ate the meat and what was available to me to be respectful to people if they serve me food in their house or things like that. So it's just kind of like having to put certain things aside because we've learned that the way people live around the world is not always the same as the way we live, in our own homes. But also, you start to see the humanity that, in many ways, humans are very similar, and the
Mm.
way we socialize, the joy or happiness, the things that cause us pain. Um, and I think public health and global health, in particular, is very beautiful in that way because it does bring us together.
I love how you're talking about these soft skills as skills that a health researcher could use. I mean,
Yeah.
anyone could use these skills in any field, but from your experience, it's great to see it. I also found language to just open up a whole world to me through learning Russian in the Peace Corps, and
Hmm.
I love that you added that. I hope people interested in global health, students or others, um, if they already speak another language, it's a great opportunity to leverage that to connect with people. And
Hmm.
if they have interest to learn another one, it just opens up a whole world. So that's
Yeah.
that's great.
And
Well, that was
let me just
yeah.
say, can I just say a few more things, just very
Yeah,
quickly?
sorry.
And just to hopefully encourage students that there's many different ways that you can be involved in global health, and so we don't all have, like I said before, we don't all have to be the best with working with data. We don't all have to be the best with language. So find your niche, right? Find the thing that you're passionate about, and um, I also will say that in my current role, I do realize that like leadership and diplomacy are very important. So anyone who is studying public health, and if you pursue a master's in public health, you'll see that a lot of the projects are going to be group projects. And the nature of our work is very collaborative, and everything I've talked about today would not have been successful if we weren't working across different teams, people who have all these different skill sets and responsibilities. And so that's one thing I've learned is like communicating clearly, being organized, and attention to detail, all very important, but also just like being diplomatic. And um, there's a lot of levels in public health with leadership and kind of understanding that there are hierarchies, and sometimes you have to kind of play into that, especially if you're doing global health and you're working for a government of one country that's going into another country. There's a lot of things that I've learned, and sometimes I learned the hard way. I know that my boss at CDC had to tell me, you have to be careful about, talking about political things sometimes, because when you're overseas or you're working in the embassy, it's a different kind of situation than what I might be talking about with my friends in my house. So, yeah, I think those are some of the key skills I would highlight.
Thank you for adding them. Diplomacy is another one of those skills that will be helpful in any field, and especially global health. So
Right.
that's amazing. And just thank you so much for your time, Nikhil. Those were all my questions. I think this is great
Yeah, thank you.
information. And I'm going to link some of the programs that you said next to the video. So I hope people look
Great.
those up if they haven't heard of them. And yeah, thank you so much for your time.
Yeah, thank you so much. Have a nice day. Thank you. Oh, I rambled. I'm sorry.
Hold on.
It's so hard not. You were like, shut up. I'm sorry.